La idea es Jaime. Mm, så كمان أنا عايزة أتكلم بس مع الجنسة اسمها الجنسة هناك.
By the time he says it, it's done. It just maybe get done.
Okay, good morning, ladies and gentlemen. May I welcome you to the Lusaka Apex Medical University guest lecture. Our sincere apologies for our late commencement. But I can assure you that we won't take too much time proceeding from here. So maybe firstly, I wish to welcome you all and to also take cognizance of the people that are present here. I wish to welcome and recognize the presence of our Deputy Registrar Academics, Ms. Charity Nashoni. Thank you so much, Madam, for being present. I also wish to recognize the presence of our Assistant Registrar, Ms. Lesina Piri. Madam, thank you so much for making time to participate in this important meeting. I also recognize the presence of the various heads of department that are present here. Due to maybe lack of time, we may not be able to allow them to introduce themselves. I also want to recognize a special person that we have amidst us. We have the Vice Chairperson for ZUPP, Mr. Obi Chomba. Thank you so much, sir. I know you have a very tight schedule. I'm actually surprised that you are here. It's a pleasant surprise, and we are so honored to have you in our midst. I'm also aware that some of our colleagues are attending online. We have a few notables like Dr. Audrey Hamachila, the head of pharmacy at the University of Zambia. We also have other senior pharmacists and clinical practitioners like Dr. Wibrod Mukwambi. I'm sure there will be more people that will be joining us from the various pharmaceutical sectors. I also want to recognize the presence of other postgraduate students that are attending this meeting with us online. We have a few mentionables like Ms. Jabuli Sile from Nelson Mandela University all the way in South Africa, and other postgraduate students that are also attending from there. So you are also very welcome. So today we have a special guest in our midst. His name is none other than Dr. Paisley Ngambi. Dr. Ngambi is a man that needs no introduction, really. He's one of our dear colleagues, and we are so proud of the work that he is doing, both locally in spearheading research in his field of expertise, and also abroad where he's an advisor in the pharmacoeconomics space. So Dr. Ngambi holds a PhD in health economics from the University of Manchester. He has a Master of Science in International Pharmacoeconomics and Health Economics from Cardiff University, and a Bachelor of Pharmacy degree from the University of Zambia. Currently, he's an honorary lecturer, honorary research associate at the University of Manchester in the UK, and also at Sefako Mahato, Health Sciences University in South Africa. He's also a visiting lecturer at Fresenius University of Applied Sciences in Germany, where he teaches economics, evaluation, and decision analytic modeling. So once more, thank you so much, Dr. Ngambi, for being here with us. Today's presentation by Dr. Ngambi is titled Health Technology Assessment, HTA, a Pathway to Evidence-Based Healthcare Policy and Practice. So without further ado, may I welcome Dr. Ngambi to give his guest presentation. Dr. Ngambi.
Thank you very much, Dr. Ngambi, for that introduction. And probably apologies that we ended up starting very, very late as planned. But I'm sure those that can stay up to the end, we're happy for you to stay. We're gonna have questions and answers at the end of the presentation. But if there's anything really, really pressing, I'm happy for anyone to just shoot and ask the questions so that we can have a discussion. This is gonna be a little bit more engaging than just me telling you stuff that I know, and I'll probably just ask because health technology assessment is really more about how we live our lives and what we really do and the decisions that we make around the healthcare space. So my presentation today is going to be health technology assessment, and we're looking at the pathway to evidence-based healthcare policy and practice. Initially, I'd written STA in Zambia, but I thought this is a really broad space that in case we end up anywhere other than Zambia, like I'm practicing not within Zambia and somewhere else, these are the same principles that are applied anywhere that you can go, and they're quite standardized. A few ways of how decisions are made from country to country might be different, but the principle and the core pillars of HTA are the same. So without really taking so much time, I mean, as usual, it's always important to kind of understand what is it that we're talking about. And we're going to look at the definition of what health technology assessment is. I'm a health economist, I'm a pharmacist, and most times there's some sectors that think health technology assessment is all about health economics. But this is much broader than that. Because we are looking at it to be a multidisciplinary process. So it's not just pharmacists, not only doctors, that's health economists. There's actually patients and different stakeholders that are involved in this space and final decisions that we make within HTA. So the main core business of HTA is to assess the medical, the social, economic, and ethical issues related to health technologies. And you look at the effects and impacts to inform policy decisions. What you look at is it includes both the direct consequences and the indirect consequences and supports evidence-based allocation of health resources. I think as we go down the presentation, one main pillar that we have to understand is resources are limited. And people might think of resources as money, but it's even beyond money. It's a time. Like we are here, you can't be anywhere else. That is your resource. So you've chosen to spend it here instead of spending it somewhere else. There's some benefits you've forgone. Perhaps you could be earning millions by now, but you've chosen to be here. So at the end of the day, we want to strike a balance. And this is why we look at both the direct and the indirect consequences of the decisions that we make. I'm sure, let's see, I just want to find out what is the lowest school year that we have for the students in? Is it all fifth year? Or are there 40-year-olds first years? No one. Pharmacy, is it the majority here today? There's always three things that you learn when you come to pharmacy. And this is the core principle of ZAMRA, where you look at the quality, what's the other thing? And the other thing? Three things. Quality, safety, and efficacy. That is what ZAMRA is concerned about. And this is pretty much where you're looking at marketing registration. That's what they do. So with them, when you look at efficacy, it's just about does something really work in ideal conditions. But as we all know, things are not always ideal. Efficacy information, you get it from very clean, clearly set criteria within randomized controlled trials or some sort of trial. But when you go in practice, you realize that patients vary, the conditions vary. Those strict criteria that you had within your trial may not be what's prevailing on the ground. And this is where HTA now comes in. And it's at that point where you're seeing after marketing authorization, it's very much around there. How do you select what goes into the system? How do you pay for it? Or how much can you pay for it? And that's where HTA comes in. So that by the time you get to procurement and really up to the end of the patient, at the point of use, you would have made one of the critical decisions at that point. And this is why those are the three pillars I talked about for ZAMRA. But then there's another hurdle. Like I said, resources are limited. There is a case of affordability and there's a case of cost effectiveness. And what you want to understand is, does this really work in the real world? So beyond that, what does this do? And that's where HTA comes in. What are the things that HTA, or when you talk about technologies, in a few spaces, I think some people, when they hear word technology, they assume it's probably something to do with computer or something to do with AI or some machine and stuff. But health technologies can be anything. So it could be a medicine, vaccines, could be a health program, clinical interventions, it could be a surgical intervention and those sorts of things. All those are referred to as health technologies. And then what does HTA look at? As usual, of course, we want to look at the safety, the clinical effectiveness, which again, there should be a very, very clear difference between efficacy and effectiveness. Who can tell us the difference? One of the students. Difference between efficacy and effectiveness. Anyone? Anyone? These are the words that you use. I mean, you throw them around. Anyone. Don't look down, don't look down.
They are seated that side, so you can point at it.
And any. Let's see, 1, 2, 3, 4, 5. Yes, sir. That's it. Yes.
So efficacy is how the drug works and its oncology point. And now when we talk about effectiveness, you are now, it's no longer visualize the impact it has after the
Oh, thank you very much for that answer. And again, like I'm saying, efficacy in clinical trials, does it work in ideal conditions? Effectiveness, does it work in the real world? People are different. What happens when you give it to a pregnant woman that you exclude in a clinical trial? What happens when you give it to a baby or children that you exclude in clinical trials? So that is the effectiveness. So that's what we talk about when we're looking at HTA. It's not clinical efficacy, but we're really concerned with clinical effectiveness. And then there's the economic considerations. We have the resources and the budget impact. If we have the resources, how does it impact on the budget that we have? As I think some people, there's one saying which I find actually useful within health economics, which is also from some Pemba proverb that, is it what Uwunga, Putman Amensh, or is it Amensh or the other way? Which is which? Which is which? Amensh, Putman, or Wungai. You cannot cook more than you have. You have a limited meal. Your water has to go into there. So it's like you have a limited healthcare budget. Whatever you do, you cannot produce everything, and you have the population to treat. You have to fit in there. And then, of course, you look at the ethical issues, the equity issues, because most times, like I said, in a clinical trial, you might just look at, it works in the clinical setting. But what are the ethical issues? What are the social issues? You give it to a population where they have certain beliefs, and maybe they decide, you know what, in our belief, we're not going to use anything if it contains blood or this and that. Those are the things that you actually have to think about, because you have all this load of treatment or this intervention that might come. You spend on it and then realize the people cannot use it. So those are the things that you also look at. And at times is one space that most times we don't talk about, and these are things like equity and equality. You find that maybe one of the groups might be disadvantaged. You give it to this. I think during COVID, we learned of something when you're doing your oxygen saturation, where we realized most of the machines are not very good with darker skin. So you have this intervention, which the world has accepted, and you realize that what it measures on a darker skin is actually quite different from what it would measure on a lighter skin. So if you procure all this, does it really work for the situation? Does it really work for the population? These are the things that HTA tries to actually consider. And does the patient really accept it at the end of the day? In an overview, there's probably I could talk of 3 things that you do in HTA. You're going to assess the evidence that you have. And within the assessment, you look at the scientific process. You're going to rely on the data that you have. You're going to rely on the studies that you have. And of course, what other evidence you can really get. And then you look at the appraisal. Within the appraisal, this is where you now bring in different stakeholders. A research might have been done by a pharmacist, but then you look at who are the players within this space. When they come in, what do they sort of decide? They appraise the evidence and then look at, does this really fit for purpose? Does it fit for people, population and stuff? And this is where you sort of appraise the evidence. Appraisal, the methodology is sort of there, but it's not set in stone. People sit around and sort of just decide and think, this is what might be the deliberate, and at the end of the day, you come up with a recommendation. You could rather say, yes, we can actually use this within our settings. We can use it for our people, or this is not really good for us, maybe we can pass. And why is HTA important? First and foremost, it ensures value for money in health investments. It promotes equitable access to effective interventions, and it also facilitates transparent and consistent reimbursement decisions. And lastly, helps to set priorities within the setting, and especially in some of the low-income countries. I know at times we behave like we're even richer than the West because we think we can afford everything until we're hit realize we don't have that many resources. So how can we actually use health technology assessment to do the best that we have to, of course, deliver our core objective as people within the healthcare space and the different stakeholders? Again, I think just at this point, what is our main objective as people working in the healthcare space? I think we probably have one single objective. At this point, I'm going to pick another random gentleman there with the hands folded. What is our core objective as people in the health sector? What's your core objective when you're out of this place? What is it that you want to do? Besides getting a salary? To help patients. Yes, that's our core objective. Want to help patients. Want to improve our population health. It's one patient at a time, but overall, as a nation, as a community, we want to increase health, want a healthy population, and of course, that creates wealth, and we can all flourish at the end of the day. That brings to more of my daily bread in terms of what is I put health within the brackets. Generally, what is economics? And economics, you can look at it in two parts. First, as a topic, and second, as a discipline. So as a topic, you look at, it implies a set of aspects such as what are the problems out there that we need to understand, we need to resolve, and some of the things we need to investigate and issues to be explored. That's as a topic. As a discipline, which I think when I got into this space, I just think economics should be mandatory from secondary school. It is a way of thinking. Like I said, the bedrock of economics is resources are limited, and it starts at an individual level. Time is limited, type of clothes you have are limited, everything else you have, even the amount of food you have could be limited. How best can you maximize your intended objective? And within that, it implies the conceptual framework or theories that are used to bear upon the topic. Here's one question: is life or health priceless? I think at the end of the day, there's an oath that people in the health sector really love to make and promise to do the best they can and deliver to the patient. Do we lie to the people, or can we actually deliver what we give oath to? Is life priceless? Madam, it's not priceless. How much is your life? Or what's the worth of your health right now? You can't tell. How much would you be willing to pay in case you fell ill today? Let's say you are 40 and you probably would die within a day. How much would you pay to live 6 more months? What's the maximum amount of money that you can pay? You love your life. How much would you pay for that? For 6 months, can you pay, let's say, $10 million? Yeah? Or at that point, would you ever say, I think the people remaining behind can use this money instead? And where do you lie on that one? Who say life is priceless? Everyone. We should do anything we can to preserve our health at all costs. At all costs. What would be the one thing that would stop us from doing that? At all costs to be alive. Is there anything that will stop you from that? We've talked about scarcity of resources. We need to make choices, and we have to make decisions. That's economics. And there's what is known as the opportunity cost. I think health economists will always tell you what the opportunity cost is. You know, you could be in the same class, pay the same fees, but the cost is different to each one of you. Could be paying 10,000, but actually the cost is different to each one of you. The price is the same, but the cost is different. Does that make sense? At what point would it be different? What are the things that you'd say, yeah, it's different even as much as we're paying the same fees? I'll pick the lady. At what point would the cost be different even when you're paying the same fee? Based on where it comes from. Expand on that. Give us an example that you can relate. Because there's always the opportunity cost. You find that you have 5 siblings, the income in your household is 10,000, and that's the 10,000 you need to come and pay for your school. What do you do? I mean, they have to make a choice. Your siblings remain hungry, and you get the 10,000. And here's another person, their income in the household is like 100,000. They come to school, they're paying you 10,000. They have maybe even 2 siblings. The cost is different. What you've given up is your siblings going hungry, whereas the other one, nothing. And this is the same even within health. That one thing that you do might not really be exactly the same price. It might be the same price, but the cost is actually different. Even when you pursue the objective of treating someone or being healthy at all costs. This is quite a common picture, I think, when you talk about equity and equality, that you might have probably seen it. So that time you see this, those people, you give them exactly the same thing. But at the end of the day, someone is not being able to watch the match. There's a little man there. But then within the economic space, I think, can we actually give this person 2 stews? And maybe the other one doesn't really need that, you know? But at the end of the day, what have we done? Everyone is happy, everyone is watching the game. And you've just not pursued something inefficient, because giving the big man a stew on the left, he's still able to watch the game anyway. So what have you achieved? Nothing on that game. You want people on that other end where everyone is happy, the population health is happy. So there are times, you know, we have to decide, where do our resources really work? Can we actually give these people instead of this one? And even like we're talking about, you know, with this, what would you choose? Given a choice, what would you go for? How many go for the car? This was the price. This bike was actually 4,000 pounds. The car was 1,000 pounds. See? Yeah. I got this right on the internet, and this was the advert where I can actually buy it. With our parts, how much is that now? A lot of money. Probably close to 160,000, there about 150,000 there about for a bike. And then you could get that car for about 40,000. The objective is for you to get from point A to point B. That is it. But then what do individuals pick? Some of them would say, I want to buy. Some of them would want to say, I want a car. But as a society, it's like we're all dealing with one budget. How best can we actually decide what to go for? The same with this, I'm sure I've heard of hip replacements. It's not a really cheap procedure. The idea is you want someone to be mobile. As a society, we might want to be thinking, should we give them a wheelchair instead? They'll be mobile anyway. Or should we give them a hip replacement? So that they can actually be walking on their own. But this is now you try to think, if a wheelchair is costing you 1,000 and the hip replacement is costing you 100,000, as a society, again, you have to make a choice. We try to think, where can we do? Do we get 100 wheelchairs and make 100 people mobile? Or we actually get one hip and make one person mobile? What is your objective? Like we're saying, we want to help a patient, but at the end of the day, one patient at a time, but overall, there's a whole population. That's why I say we promise to do something for one particular person, but then there's another promise we have to society. How best can we actually use these resources? We get 100 moving, or just use one. It can be complex at the society level, of course, because different people have different preferences and want to sort of take that into consideration. And this is why economics again is split into, there's times you hear about why economists don't agree on something. There are two areas of economics, the normative one and the positive one. The positive one is the numbers, this equals this, what are the stats? The normative economics is how things ought to be. Do we give the odd man the hip replacement, or should we do wheelchairs? Morals come in, different society beliefs come in, and as a society, within HTA, this is where we come in and say, how are we going to live? And this is the normative side of things. And when we talk about opportunity cost, like I said, within the health sector, want to maximize the benefits, want to deliver the maximum health we can. So if we're going to treat 10 people, would you rather treat 10 people or treat one person? At that point, you end up starting making choices, in as much as we say we can do anything to stay alive or to stay healthy. But when we're in this space, choices have to be made. Do we buy vaccines, or do we buy malaria drug, or do we buy half and half, like the picture we saw, half and half, but then you realize that maybe we're still not achieving what you really want. Then you maybe buy vaccines, something suffers, but at the end of the day, the population health is improved. And what sort of happens is you have this limited budget. I think every year the budget is presented, health sector has been given this, whatever happens, what do you do within that? So you probably have like different interventions that you have within that, and you're looking at we have the health benefits and the healthcare expenditure with a limited budget. And the idea of HTA is, like we say, want to improve population health. So what do we do? Want the good things to come in, but because our budget is limited, we probably have to let go of some of the other things. Can we change our treatment guidelines? Is it really worth it? And ultimately, if you can see, if those were the new treatments, and remember we talked about the concept of opportunity cost, and this is what we give up to gain something. So opportunity cost is sort of set at that line. With the current treatments, this is the lowest, so whatever we do, this is where we are. And what we want to do is, we don't have to bring in that treatment. If it costs the same, we put it there, what we do, we've actually lost that point. That's not what we want. What we want is, can we be able to afford to bring in this, but ultimately, this sort of goes out. And what you sort of end up with is something like this. You push your treatment, something new comes in, it delivers more bang for your buck, but then you sort of get rid of what you had. What happens? The opportunity cost is kind of increased then at that point, and that is the new one. And you can sort of still keep, is there anything new that comes in? And ultimately you realize that before the new treatments, this was the opportunity cost, this was your maximum population health. After you introduce something, sort of on that. The budget has remained the same, the cake has grown. It's probably become more efficient in how to produce a cake, and that is the aim of HTA. At the end of the day, we've delivered more for a very fixed budget and for the fixed resources. And how do you make decisions? I think I sort of touched on this a little bit. And I just wanted to give a bit of where I work and how we decide what goes to who and in HTA decisions. And this is made by a committee and not really one individual or just expert people. So within that, you look at the scientific judgment. This is where you look at, here's the evidence that we did, here's the research that we did. What is it that you have? Then you have the social values. I mentioned, how does society feel? What are the things that come together? How do they really agree on? And ultimately, there's the best available evidence. There are times a decision always has to be made. I think it's quite common within healthcare research or research at times where you end up with a conclusion of more research needs to be done. But while more research needs to be done, a decision has to be made. Do we go with the gut of this? It says this actually might work. And we're talking about uncertainties and probability, but we're looking at what is the probability that it actually is likely to deliver to the people that we're researching and put this work within the system. And that's where we end up with what's the best available evidence. And of course, overall, there are times you want to say the uncertainty is maybe 10%. do more research. Maybe it's costing you 100,000, and that uncertainty, if you went with maybe 10 out of people might actually not really benefit from this treatment, you realize that your research might actually be more expensive than that uncertainty. So you have to make a decision and say, with the uncertainty, even in the worst case scenario, 10 out of this many people might actually not really benefit, but we have to make a decision and just go down with what we're doing. And that is where use the best available evidence and make the decision. How do we make the decision? So there's, of course, where you look at, we've talked about within economics, there's the cost side and there's the benefit side. One of the common figures you might probably come across if you're reading a pharmacoeconomics paper, a health economics paper, is what is known as the cost effectiveness claim. And within that, you're trying to look at where do you sit between the cost and the benefits that you deliver. And it sort of looks something like this. Looks like it's not changing too. My slides have gone way ahead, but this is not changing yet. Yeah, Zoom is disconnected. It's only connecting. Okay, the cost effectiveness claim. So we have the measure of health on the x-axis, and you have the cost on the y-axis. Has anyone ever come across this word called the QALYs, which is also called the quality adjusted life years? Is it a concept that someone has come across? Everyone? Yeah, so you have on the y-axis the cost, and on the x-axis the benefits of the quality. What is the quality? Anyone to shoot quickly? Quality adjusted life years. Anything, any answer is acceptable. Any answer, any answer. How does it measure the value of health?
Like, the number of years, for example, 1 year is equal to the value of health.
Yeah, that's perfect. Because quality adjusted life years, we're looking at the quality of life within a year. And of course, your life could be at 0, you're dead, or it could be at 1 year. And perfect health, everything works. So when you talk about one quality, it means 1 year of life in perfect health, no pain, no nothing. Probably going by the WHO definition of health, which is one of the broadest definitions, and I'm not sure that's attainable. Well, that's the idea of the quality in there. So within that, what we want to understand is you have different quadrants. So the northwest quadrant, where you're looking at something is less effective but more costly, and you're thinking, why should you invest in such a thing? Pay more for less outcomes. And then you have this quadrant where something is more effective and costs you less, because here costs are going down, the health is going up. In the ideal case, if there was a way, we would always want to be here, because then you're going to save more, you're going to produce more of your health, you're going to produce bigger cake than you had before. But the trick becomes where something is less effective but also less costly. And this is where you're trying to think. We used to have 3 meals. Things are bad. Instead of buying a 25 kilo, can we buy a 10 kilo? We've gone down. And within that, Instead of having 3 meals, can we have 2 meals? You're going to be in that quadrant. That's costly, of course. But again, you're losing out on having 3 meals. So what do you do within that space? And the other space is where it's a bit more expensive, but more costly as well, and works better. And it's in that space where you think, can we still buy a 25 kilogram and have 3 meals? It's going to cost you a bit more. The price of meal has gone up, so it's costing you a bit more. But then you could sort of deliver the 3 meals. And that's the other space. And these are really the contextual spaces that you kind of have within cost-effective split. This is where decisions have to be made. Do we cut the meals we eat and sustain our money, or do we actually pay more and just sustain that? But like I said earlier on, it's about how much resources you have. Your budget is limited. You might want to push out maybe breakfast. Like we said, does your satisfaction still maintain, or do you actually bring in something else to kind of give you the maximum outcome of the objective you want to pursue? And the decision ultimately is made with what is known as the cost effectiveness ratio. And with the cost effectiveness ratio, we're looking at the difference in the costs of 2 options. So it could be option A minus option B, which would be the new treatment. And then the outcomes you also try to subtract. And what you get is what is known as the ISA, or the incremental cost effectiveness ratio. At that point, you then sort of decide where do you lie. If it's costing you, let's say, 100 kwacha to produce 1 quality adjusted life year, and then you look at the difference, you end maybe getting maybe 10 kwacha per quality. Is that what you sort of pursue? And what is your maximum that you can pay for? So the decision is always made. There's what we call, there's normally a threshold that you might have and say, maybe if it crosses above this line, probably we don't have those resources. We always want to be below that. And you use the incremental cost effectiveness ratio to sort of make that decision in pharmacoeconomics or health economics. And ultimately, and we can talk about HT and evidence-based policy. So what you want is to link clinical evidence with the real-world decision-making, and then to ensure public health policies are grounded within robust evidence, and of course, support reimbursement and coverage decisions. We're talking about NEMA. I think we have NEMA, resources are limited. Our pursuit is universal health coverage. How best can we reach everyone with the contribution that we make? So at that point, I think we want to help make those decisions. And this is where HTA gets to inform evidence-based policy. How much time do we have? Do you think we can have 10 more minutes? Yeah. There's other slides that I thought we could still share. This was going to be the end, ideally, but I just thought I could introduce you to a few things of how we measure health. And like we talked about already, in terms of the quality adjusted life here, and the objective within health is to improve population health. We have a promise to the patient, also have a promise to the population. How best can we improve that? And this is the WHO definition of health that I was talking about. A state of complete physical, mental, social well-being, and not just merely the absence of disease or infirmity. With this definition, how many of us are in perfect health right now? Physical, yeah. Mental, social well-being. How many of us are in perfect health today? Are we all patients then? So at the end, with this, if you're going to make a decision of improving population health, then you want to say, how do we measure this health? What are the things that we sort of do? And you look at the 2 things. One of them is the health status, which is quite descriptive. State of health: are you able to walk? Are you able to eat? Are you able to do your chores? Are you able to bath yourself? And of course, there might be different dimensions, but you want to bring it all together. And this is why I say the quality of life. What does quality of life mean? With the different, if I'm able to walk, someone is not able to walk. I play football, I lose a leg. This is someone that plays basketball, lose a hand. Where is our quality of health? What really matters to us? And this is where we then want to go beyond the descriptive stuff of this one cannot walk, but what does it really mean for the quality of health? What is their day-to-day way of life? And in this case, we sort of want to measure how much health is actually gained without the suit. And then this is where we talk about the health-related quality of life. And some of the data sources, of course, we can have the randomized controlled trials, observational data, registries, and administrative databases, and all sorts of research that we can do to get this information. And in health economics, you're going to come across things like the cost-effectiveness analysis. You might have heard of that. There's a cost-utility analysis and there's cost-benefit analysis. So clear crash costs. From here, you can call yourself a health economist if you know these three things. Cost-effectiveness analysis, you're looking at the outcome is a clinical measure. You know, how much have you reduced someone's blood pressure? How much have you reduced someone's sugar levels? What does it really mean? Cost-utility analysis, what is the quality of life? How do you measure that quality of life? You bring in the qualities. And of course, the cost-benefit analysis that a lot of people throw in and confuse with cost-effectiveness analysis. And probably a lot of people on the street who use this word. All you're looking at is monetary outcomes for both of them. So if I treat you using 10,000 parts of medicines, what is the outcome? Am I looking at maybe how much are you gaining? If you get back to work, if you earn 20,000, then I think I've probably done a good job because I've produced more for you as you step out of my clinic by using less resources. This is where cost-benefit analysis comes in, which is quite tricky to measure at times within the healthcare space. That's why cost-utility is actually quite easy and straightforward, because then we don't really bother with someone's income, but we can try to think about what is the general measure of quality of life for everyone. Yeah. So these are the different outcomes that I was talking about. Utility, qualities, benefit, money, cost effectiveness, clinical parameters, life years gained, complications averted, decrease in blood pressure, and those sorts of things. Measure of quality of life. Here's a really nice cartoon, you know. A long time ago, I think it was asked, can you increase someone's lifespan? But here's a person that's bedridden. And I think this cartoon does deliver quite a good message where the doctor says, the bad news is you're going to be in pain, excruciating pain. But the good news is it's going to be for a very, very long time. Who would want to be in that state? You're going to live probably forever, but you're going to be in excruciating pain. And this is where people in the healthcare space or within HTA and health economics decided we should have a balance on the quantity of life and your quality of life. Maybe I want to live just for 6 months, but if we can be perfect health, well and good. As compared to living 10 years of my life bedridden, very terrible, terrible pain. And that's the sort of balance we want to strike. And this is why the quality came in. And we want to include both the quality of life as well as the length of life, which is the life expectancy. Something that you probably hear mostly is what does a quality of life, what does one quality mean for different people? What does half a quality mean for different people? Because like I said, a few things might mean different things to different people in terms of what is your day-to-day life. What are the things that you live with? You know, how many here think they have a disability on a disability form? How many? Can anyone think of anyone here that has a physical disability?
I wear glasses.
Thank you very much. Yes. The people with glasses, you know, we just take it for granted because it's corrected, you know. You take off your glasses and you have this disability, but those are some of the things, and you know, your quality of life has improved. It's probably close to perfect. But what happens if you just remove the glasses, you know? There's this intervention. Can you see me there?
Yeah, I can still see you.
Is it? But then, depending on, you know, some of us, it might be the eyes, someone might be the legs and stuff. But if we have one common measure, we're bringing all this together and we say, this person have half a quality. What does it mean for different people? And we say, it could be the eyes for one, it could be the leg for another one, but half a quality means half a quality, and it's that. And this is what society sort of decided. And there's value sets that we sort of use when we're kind of measuring some of these things. If you have time, look at some form called the EQ5D. or Eurocore 5D, you get these 5 dimensions of someone's health and 5 levels of their health. And then you have a value set you can actually then use to calculate what the quality is for each one. So if you want to play around in class, just pick that and see what value sets you get for the class. You can actually get the average health of the class and And why do we use equality? Like I said, things are different from one person to another. Something might extend your life, but not improve your quality of life. Something might improve your quality of life, but not extend your life. But at the end of the day, we want one common measure that we can be able to compare to, even when we make decisions within the healthcare space. Yeah, I think that if you are really, really interested in just going deep and reading some of these things, these are some of the go-to textbooks. Mike Drummond, I think, Methods for Economic Evaluation in Healthcare is like a go-to for everyone working in this space. And of course, there's cost effectiveness analysis and in healthcare and cost effectiveness in health and medicine, which you can sort of read. And this is the end, and we'll take questions now. Let's just all have a chat.
All right. Thank you so much, Dr. Ambi. That was a very interesting and thrilling presentation. I have no doubt that we were all engaged in that. We have some interesting questions to pose. Maybe I'll start.
Please.
Yeah, I want to ask you, because you see, from your presentation, I think one thing that I didn't sort of think about, but I'm now beginning to realize, is that even when we look at a basketball player, the analogy that you gave, a finger to a basketball player has high value, but a football player maybe not so much. And then a toe maybe for a football player might be so important. So the value is different depending on what who the person is and what they term as the quality of life. So I want to venture you into some of the patterns that we've seen, especially in the US, where there is what they call body part health insurance.
Yeah.
We've heard that Kim Kardashian has insured a particular body part, and so on and so forth. Even footballers, they do things like this. I just wanted you to comment on that. What are the intricacies of that, and do we foresee such practices being adopted into our setting from the Western world?
So I thank you very much. That's a really good question, and this brings us back to what we're talking about in terms of as a society. Like I was saying, we have NEMA, right? So if we have NEMA and we decide, you know what, if you want a butt lift, everyone should be able to get it because it makes you feel good, it improves your well-being. But like we said, we have limited resources. So as a society, at one point, we have to say, what is it that we can pursue? At an individual level, it sort of becomes a bit different, like the bike, BMW choice. Someone might just easily pick the bike, or someone might pick BMW because we don't, it's how you're spending your resources. Within yourself, they also might be limited. You might have 1,000 and you want a bike that costs 4,000. What do you really do in that case? So at an individual level, I think it will work. Or it's even happening now. Well, some people prefer to go to outside the country when they have a problem and stuff, they're spending their resources. But if we decided to spend our society resources and say everyone that gets sick, we can just evacuate them, can we afford that? We have a limited budget.
Yeah.
So societal values come in, societal decisions come in, and with elected decision makers, and of course involving everyone, you come to the table and sort of agree and say, for instance, I'll give an example, the UK. Every new medicine that comes on the market is evaluated and it comes through what we call NICE, and that's the place I work for. Within that, we sort of decide, can we pay for this as a society or can we not pay for this as a society? Recently, what made the news, I think on BBC People, where you see a dementia medicine that NICE decided was not really value for society money because it was only delaying dementia for 6 months, but of course costing thousands of pounds, hundreds of thousands of pounds. So we thought, if it's on a delay for such 6 months, is there anything better we can actually do with that money for the whole population? So it sort of comes to that. And so part insurance, so body part insurance, some individuals might do it, Even, I mean, some individuals get like really fancy glasses, they get labels and cookies and all. And then there's me that probably won't get one from the automarket just as I can see.
Thank you so much
Great.
for that response. So we invite you to, if you have a question, we can also look at those that are online if there is any question from them. Okay, so maybe I can start with a question from Andrew Kaonga. So his question says, what's the way forward for the private health sector in health economics at a Zambian perspective, and because DRZ alone cannot harness the healthcare burden? So what's the private health sector in health economics at a Zambian perspective?
Good. My personal perspective, first and foremost, for a country to kind of develop, a country develops because of the support that you might get from the private sector. And this is why NEMA sort of is not segregated. We could be a private player, but we could still be part of delivering health services to the whole population. And I sort of want to just strike innovation versus the profits that you make. And from our forefathers as well, kind of pay for this. And it's of course clear, GRZ might not manage everything on its own, for personal healthcare setup where we've promised universal healthcare coverage. Does anyone understand what universal healthcare coverage is? Student, which one is going to give us that? Universal healthcare coverage. Similar to the oath that we all make at the end of these programs, we've promised to deliver healthcare every person, regardless of their ability to pay. So I think within that space, we then also have to understand what our resources, what our limits. We sort of then decide, like I was saying, should we pay for things like a hip replacement, or should we be buying people wheelchairs or crutches for them to move because we want to cover everyone else. Private players, of course, are delivering these services as well. They can come in, they complement GRZ services, they complement what the government is doing. But of course, what is being paid is still coming from taxpayers. It's still coming from people contributing to NEMA. And we kind of have to sort of agree, even with the private, what is it that goes to them and what are the decisions we make. But I think, of course, there is space. We have to balance innovation and support. We also have to balance that the budgets are limited. The GRZ resources are limited. What is it that we can pay the private to make everything sustainable, because we just don't want to go for flashy things on the outside and then suddenly the whole system collapses.
Yeah. Thank you so much. Yes.
For those that don't know me, he's my very good friend.
All right. Thank you so much, Dr. Ngambi, and it's always great to have you back home. First and foremost, you've done well for yourself in this space of economics. And I think as a profession, we value your contribution in terms of research everywhere or globally. I'll bring you back home, looking at the fact that Zambia's population is growing. I wanted to find out how best is Zambia implementing the HTA as far as universal health coverage is concerned. And also, do we have expertise that would be able to help us attain universal health coverage vision 2030 of this mission?
Thank you very much. That's another really good and loaded question in terms of, first and foremost, what is Zambia doing in this HTA space? And as a nation, do we have the expertise to deliver this vision by 2030? To start with, there's quite a number of brilliant people working within this space, who, if we get together, we can actually do more. In terms of HTA, Zambia has not really started doing HTA, and this is probably some of the things that maybe eventually they'll be able to do. It's quite interesting because there's one project I'm supporting Kenya, and Kenya is sort of supporting Zambia, so going around, and maybe some things probably might be done directly at some point for the HTA space, and the sustainability of things like NEMA do really much depend on HTA decisions that we make. And within HTA, like I said, it's multidisciplinary, and we don't want just, a few elite sitting and deciding, maybe even on the package, what is it that you receive? Maybe 1 minute you go that you can get dental care, the next minute you go, you can get dental care. The thing is, it's not that they've done something wrong, but maybe it's just not well communicated and expectations are not well managed. So within HTA, we bring different stakeholders onto the table and say, this is our piece of cake. How can we share it to make, the best that we can? And I think Zambia sort of needs to go down that direction as well. Slowly start incorporating HTA. And as health systems grow, the health systems improve, the HTA mandate kind of really has to also grow in terms of what is it that you can do. For instance, for very low hanging ones, we used to have like rural health center kits. If anyone has kind of worked in government, there's just a package. These are the basic things that everyone can get, and they just go. But within that, realize that some of the things are just sitting at some healthcare center because not everyone is using those things. As you go, you want to look at what is it that you can deliver. How are we making these decisions instead of just one basket and give for everyone? Like the analogy I gave, where you give a scoop for everyone and just think, maybe someone in Lusaka doesn't need so much of this part as compared to someone in Sparta, for instance, or in a rural place. How do we make those decisions? And when we bring in HTA, it can really help us. And 2030 might be too soon, but we might get there. I think if we get our systems in place.
Yeah. Thank you so much, Doctor. So another hand, Ms. Chisulo. So Ms. Chisulo is one of our heads of department. She's the HOD for the Department of Applied Sciences.
So my question was directed towards decision making, because from the presentation, I can see that part of the HTA process has to involve the society values. Are there times from your experience looking analyze when we make decisions and then those decisions go against the society values?
I wouldn't actually say they go against the decision or the society values. What has really happened within the space of national distance, for instance, for the last 25 years is very, very strict involvement. There's even a policy about how to involve patient stakeholders, even within the committees of how decisions are actually made, which is actually open to the public. So, and now that things are even online, everyone can actually register and listen to the deliberations. Within the decision making, there's even people that you call lay people and patients themselves. So they see part of that, they don't even have to really understand the economics, but does it make sense to the common person, and does it make sense to the patients? Really, and those are some of the things that kind of made. A few times we get a backlash from a few people always have interest. Like I was saying, the dementia example I gave you, a bit of that, but overall, what does society subscribe to? What is it that they've agreed on the principles of our work? And there's constant engagement as the citizen stands. So there's patient involvement. So it's actually quite good. And these are some of the things that we tend to overlook as researchers within this part of the world, where you do some really brilliant research, but have you even spoken to the patients and you've spoken to society? How do they feel about that? And this is where you find that maybe some research might actually just end up being shelved. Is it speaking to even the decision makers? How do you sell your findings? How do you sell your recommendations? And how do you involve everyone else? I think that's quite important.
Thank you so much for that question and for the response. We are getting overwhelming comments and just positive feedback for this session. Maybe we can quickly look at some of the questions from the people that are attending online. So we'll start with Andrew Kaonga, who asks the question, what's the way forward for the private health sector?
I think this is the one we did.
Or
That's
the first one?
yeah.
Okay, so we'll go to Chimuka, the pew pusher. So he writes, given Zambia's limited healthcare budget and the growing burden of diseases like malaria, HIV, and non-communicable diseases, how should policymakers prioritize healthcare interventions? Should they focus on preventing diseases through public health measures, or should they allocate more resources to treating those already affected, considering the ethical implications of each approach?
Yeah.
Doc, did you get that question?
Yeah, so I think I'll try to respond based on how I understand this. Should we concentrate our resources on preventive interventions as compared to curative interventions? That might sort of be the approach. But like we say, this is one not in black and white. And again, as a society, these are some of the things we have to make decisions based on. What is the available evidence? Is that the best evidence that we have? How do we do that? And would we kind of do both? And maybe one gets bigger share, like we had, get the little child two stools, able to watch that. Maybe some people might not do that. You move some resources from creative areas, but what are the implications of that? And with this advice, so it's not like I can give a clear say, let's go preventive versus let's go creative. At the end of the day, like I said, it's the objective that we're all here for as people within the healthcare space. Want to maximize population health with a limited budget. How best can we do that? So there, of course, we push out things that are not working, we bring in some things that are working. And within that disinvestment, some people might be disadvantaged in one or the other. But overall, what is the bigger picture? And that's what we sort of should go for, really.
Thank you, Doc. Any questions? Okay, so we proceed to the next question from Chongo Macha. So he asks two, maybe because of time, maybe we can just pick one. So he says, what are the recommendations you should make on using HTA in guiding clinical decision-making, especially in pharmaceutical selection for patients?
Yeah, so on this one, one of the value chain I kind of showed early on, starting from research and development, you move on to getting to marketing, licensing, or regulation, and then of course where sort of HTA comes in. Because at the point of HTA, that's when you're deciding this thing is registered, it's on the market, it could cost $1 million, it could cost $100,000. As a society, should we have it in our hospitals? And bearing in mind, like I said, the difference between effectiveness and efficacy, we're trying to look at, does this really work for our population? And even when selecting medicine, it's not just because it's on the market, then we should sort of pay for it. We have to use evidence, best practice, and within that space as well, we have to include all the different stakeholders. Because what we don't want is, here's a research paper that Jonathan Katandula has done, and it says this is the best thing. There are different aspects. There could be clinical effectiveness. What is the economic value of that? How does it really look like? It should be guided. What are the ethical implications? What are the social implications of that? What are the legal implications as well? Because, there's some of the things we might even overlook, but maybe one treatment just goes against some legal statute within Zambian stuff. We all have to take those into consideration and overall guide our decision in terms of what is it that we select. We've seen things like HIV or malaria treatment guidelines, I think in my experience, which change quite a lot. So you have people that are maybe taking Truvada and something new comes in and they say everybody should move. What happens to those that it was actually working for? Can you stagger it? Can you pick a specific population of saying, no, maybe this part can actually go to this page of us, a sweeping change and all sorts of things. And these are some of the things that come within the space of medicine selection.
Thank you so much, Doc. We have a raised hand from Joe Kanema. Mr. Kanema, would you kindly unmute your microphone so that you can proceed to ask your question?
Thank you very much, sir. I hope and trust that you're able to get me.
Loud and clear, sir. You can proceed.
Thank you very much. Dr. Ngambi, this was a very good presentation, and thank you very much.
Thank you.
Mine is sort of a personal question, in a sense, to do also with on a professional level. You are really an inspiration to us as pharmacy personnel in Zambia that look up to you, and sometimes
Okay.
you may never know.
Are you able to just speak closer to the mic and speak up?
Are you able to get me?
Yeah, we're getting you, but just getting a bit low, and we're increasing the volume. Let's see how it does from our end.
Okay. Are you able to get me now?
Sounds great. Thank you. Yeah.
Thank you very much. So I was saying my question is a little bit on a professional and personal level. Just looking at you and what you've done in the pharmacy space, really commend you for the job that you are doing. For some of us that look up to you, like for me personally, I look up to you a lot because economics has always been my passion, even dating back to my days in secondary school. But then I've always wanted to see how can I mix my passion in terms of economics and the profession pharmacy. I never actually knew that you can study pharmacoeconomics until I actually heard that you've done something like this. So what I would like to find out, maybe on your personal level, as to try and mentor young people that are coming up and looking up to you, or maybe trying to provide a pathway for some of us, people like me. Is there a way that you can be able to provide maybe for me like an email address that I can perhaps just use to try and communicate with you on how you can be able to mentor or be able to guide a young person like me that is coming up and want to follow your space? Thank you very much.
Thanks, Joan. Really humbled that you actually inspired. And a quick answer to that is I'll type in my email address within the chat for whoever wants to sort of get in touch. You can also find me on LinkedIn. You can always just drop me a message. Whenever I get time, you can always have a chat and I can kind of give you some guidance on how I've navigated this space. And like you, when I went into health economics, I actually, at that point, never met any health economists for some reason. I just got inspired reading some stuff, got into that for my master's and at the end my PhD. It's of course something I would have really loved even at my time, to just have someone to speak to. It was after I'd already gotten an admission, I started speaking to some people, met some people, which was even more helpful to kind of just get the insight of what is it that they do and how that does the space really look like. And even the different areas you can practice in. For me, I think I've practiced in, I've worked for a pharmaceutical company, I've worked for a research institution within health economics. I work for an HTA decision-making body, which is nice now. And I think that kind of helps to just give you some perspective in terms of where is it that you can actually go as a health economist and what are the things that you can do. So I'll share my email address and you can always contact me and look for me on LinkedIn as well. And we can always connect, Joe.
Thank you. Thank you, Mr. Joe, for that question. Our students, is there anyone who would wish to ask or comment on the presentation? Okay, so we'll go with you, madam. Your name?
My name is Christina.
Okay.
So I have two questions. So the first question is, what are the main challenges in implementing HTA in a healthcare system, and are there limitations in the HTA process?
Challenges, first and foremost, just like the treatments themselves that want to deliver to resources. And these resources, like I said, at times it's not just the money, it's also the human resource. We have enough researchers, for instance. We have enough statisticians. We have enough people working within clinical research or healthcare research, because that's where we're trying to gather the evidence. And how informed is the whole system? Is there a legal mandate? For instance, again, I'll give you an example of what happened in the UK. Every medicine that comes on the market is evaluated. When a recommendation is made, the system, or what is known as NHS, is supposed to make that available to the patient within 6 months. So you have to have that legal backing in terms of this team must say this, the government should copyright. If you don't, I mean, there are even legal implications. As a patient, you probably could sue that this was said it's useful for the population and we don't have it. So this is some of the things we need. We need the legal backing, we need the legal mandate, we need proper resources, we need the right personnel, and yeah, including researchers and of course the funds that we can. So those are some of the challenges. The limitations, HTA, again, is not really set in stone. It's about the people and it's about society coming together and deciding how do they govern themselves, kind of what is it that they do within the healthcare space. So the weaknesses, we learn from them, you know, you improve on them. Organizations that have been within existence and stuff. Some of them learned the hard way, you know, there's some, we make decisions, like I was emphasizing on the importance of bringing in stakeholders. Early on, some you find that maybe you sidelined the pharmaceutical startups, and you sidelined the surgeons, you sidelined the pediatricians, and you make a decision, you know, as this organization, you have the view that players are really important in this space. How much are you engaging them? So those are some of the things, but we learn from it and pick it up.
Thank you. I saw another hand. Yes, madam. Your name and you proceed.
So my question is, under decision making, one of the elements that you talked about was based on evidence. So in a case where the evidence that is used is limiting or uncertain, how can you make a decision?
In terms of uncertainty within HTA, what happens is, I think that's one of the important sides of HTA, because it kind of quantifies the HTA. Within health economics, again, if you get interested in reading about this, what is known as the cost effectiveness acceptability curve, and you look at what are the chances that something might actually deliver what the results show you. What are the chances that it's actually cost effective? So looking at probabilities. So within that, you kind of try to quantify that uncertainty. And like I was saying, there's a common phrase you find in lots of research. I don't know, I'll probably say this part of the world, which is more research needs to be done. But more research, all we are saying is because you're not really certain about the result, like what does it cost you to do more research? How long does that take you? And what happens with the decisions you have to make? So you could decide to say more research is done, or you could decide we could be using this as research is being done, or you could decide this is actually really, really harmful to our population. Let's not even touch it. So there are sort of different levels of decisions that can have to be made based on the best available evidence. But ultimately, you know, there are people that think we can postpone a decision, but even postponing a decision is the decision itself. So even at a personal level, you might delay and just think, no, I'm probably not going to decide on this until next year, but you've just decided to sit and wait. And that is the decision that we've made. So I think even within this space, decisions have to be made. Even when you say this is not statistically significant because the p-value is this and that, what does that really mean for the patient in front of you and for the society as a whole?
Thank you so much, Doc. Maybe due to time, we are only remaining with maybe one last question. However, do not feel bad if your question has not been answered by Dr. Ngambi. We will forward these questions to him and find a way in which he'll be able to relay his answers. So we'll take our last question from Vanessa Mushibwe, who says, you mentioned in your preamble that you first researched on HTA in Zambia. Did you conclude your research here? And if so, what were your findings? And then say, secondly, what made you decide to research on this topic on a global scale?
Okay. So anyway, on this one, in terms of HTA research in Zambia and stuff, I've been a bit active within the health economic space, and it's really as a commentary in terms of what is it that we can do. Formalized it, I think we've not done any formal research within HTA in Zambia in terms of these are the recommendations we can actually make, and how do we actually approach this kind of space. So that is some of the things some people can take up on. Some collaboration we're probably going to do with some people within the space. And in terms of looking at the global space or why I got into HTA, it's like I said, it's easy to kind of forget and promise people heaven on earth. But overall, just like at an individual level, like I said, we have limited resources. Governments have limited resources, and all those that have gone into HTA, still the same thing. Want to deliver, maximize population health, but how can we do it with our limited resources? And I think that's a bedrock that we always have to keep in mind at a personal level, at a national level, and this is what we sort of need to really pursue.
Thank you so much. A hand of applause for Dr. Nyambe. And another hand of applause for us. I think we've done a good job in hosting him. I hope that will come from his mouth as well. All right, so that was Dr. Nyambe, an advisor at NICE. He's part of the NICE advice team. Our hope is that this is not the last engagement that we'll have with him. We are aware that he'll be leaving shortly. However, we believe that this is just the beginning of our core relationship with Dr. Nyambe. By the powers vested in me, I want to appoint Dr. Nyambe as one of our guest lecturers, with or without his permission. I will discuss with the Vice Chancellor on this note, and our hope is, because clearly we can see that this is a huge gap, not only in training, but also in practice. So we are hoping that we'll be able to have more interactions with Dr. Nyambe, and that our students will also be able to benefit from some of the things that we'll be able to learn from him. So I wish to extend an apology on behalf of the Vice Chancellor and the Deputy Vice Chancellor Academics, as well as the Deputy Vice Chancellor Research, who could not make it today due to more engaging activities. And also, I wish to let all of us know that we've received a bereavement. We have lost our Dean of Students, Mr. Siabwembo. So maybe we can just observe a minute of silence just in honor of his service to the Lusaka Apex Medical University. May his soul rest in eternal peace. All right, I also want to wish a wonderful day to those that have been attending online. Thank you so much for your participation. I think from here now, we call this meeting to end. So this was hosted by the Faculty of Pharmacy, Nutrition and Dietetics, and it has been my pleasure to be able to moderate this session. My name is Dr. Mtenta Nyambe, the Dean for the faculty. So thank you so much, and wishing you a good day.